It's 12:01. So we'll go ahead and get started. Good afternoon, and thank you so much for joining us this afternoon for our webinar on maternal health data. My name is Mary Brandenburg, and I'm the Director of Population Health with the VHHA Foundation. We're the 501c3 nonprofit affiliate of the Virginia Hospital and Healthcare Association, and we are so proud to partner with the VNPC, the Department of Medical Assistance Services, or Virginia Medicaid, and other state partners to present this webinar series on data that provides insights into maternal and infant health outcomes. Reversing the trend of increasing maternal mortality requires data-driven collaborative efforts across healthcare, community, and the public sector. With this series, we hope to bring together stakeholders and share information about diverse data sets that can inform impactful programs and initiatives. For today's webinar, our second in the series, we have a presentation from Marina Hench and Rich Rosendahl with the Division of Healthcare Analytics and Transformation at DMAS, or Virginia Medicaid. Future webinars will include presentations from the Virginia Department of Health, VHI, Virginia Health Information, and the Office of the Chief Medical Examiner. You can register on the VNPC website for the remainder of the series and view previous recordings online. Please share this information with colleagues and partners. Evan was kind enough to drop the link in our chat here, so share far and wide. And now I will turn things over to our partners at DMAS. Thanks so much, Marina and Rich, for joining us today.
Hi, thank you, Mary. Thank you all for allowing us to present some information on our program and our associated maternal data. My name is Rich Rosendahl. I'm the Chief Analytics Officer here at DMAS. And presenting with me today is Marina Hench, our Senior Policy Advisor to me on our team.
All right, thanks, Rich. As I get situated with PowerPoint. It's great to be here with all of you virtually anyway. We're looking forward to presenting our data resources. I'm going to start by just sharing really general information about Medicaid for those of you who may not be as familiar or those who are, and some of the details can be helpful. Medicaid is the joint state and federal program that provides health coverage to low-income adults, children, pregnant and postpartum women, elderly adults, and people with disabilities. And in Virginia, Medicaid is branded as Cardinal Care. Some of you may remember that we had two primary programs historically. Those were recently merged into Cardinal Care. For maternal health, Medicaid covers full healthcare benefits during pregnancy and for 1 year after the baby's birth. And additionally, we offer 12 months of postpartum coverage to the mother after the baby is born. In addition to Medicaid, DMAS also manages the CHIP program, which is the state and federal program providing health coverage to uninsured children and pregnant women. CHIP is distinguished from Medicaid in that it's for eligible families with incomes who are too high to qualify for Medicaid, but too low for private insurance. And in Virginia, our CHIP programs are FAMOUS. And then FAMOUS Moms is the CHIP coverage for pregnant and postpartum women. FAMOUS Moms covers healthcare benefits during and after pregnancy, 12 months postpartum after baby's born. And the benefits are similar to Medicaid for pregnant women. FAMOUS Prenatal is our benefits for 60 days after the baby's birth. And this program is for pregnant women who don't meet the immigration rules, but who would otherwise qualify for Medicaid or FAMOUS Moms. And postpartum coverage for this program is limited to 60 days. So with that, I'll turn it over to Rich, our Chief Health Analytics Officer, to talk about our data resources.
Thanks, Marina. So Virginia Medicaid covers more than 2 million Virginians, and we're able to visualize them with our enrollment dashboard, which we have a snapshot of here. This is available on our website. We have over a dozen different dashboards to help us provide transparency to the state and our stakeholders. But in addition to providing demographic information about our members, we can also filter to learn about these people by eligibility categories, as Marina listed out on a previous slide, the different buckets people might fall into. This screenshot in particular shows how we can look at members enrolled due to pregnancy. So we have that that capability as well as anyone else who is interested in goes on our website. Next slide, please.
One second, I'm trying to advance. Okay.
Awesome, thank you. All right, so in 2022, DMAS started providing 12 months of postpartum continuous coverage to members, which is an expansion from 84 days. This means pregnant members can remain continuously enrolled for Medicaid service coverages during their pregnancy and through 12 months postpartum. These are people that are also able to, or people are also able to enroll after giving birth during this period. So if they weren't enrolled prior to the birth event, they're eligible to do so after the event. Next slide. All right, so as we start to get towards talking about what type of data we like to look at, let's talk about one of the key sources of it. So DMAS carefully measures and monitors prenatal and postpartum metrics. We're doing that, different settings, different times of the year, and one main source of information that we use for that is HEDIS, or Healthcare Effectiveness Data and Information Set. HEDIS is actually developed and owned by NCQA, which is the National Committee for Quality Assurance. But today I want us to focus on two HEDIS measures, which is the percentage of deliveries of live births that received a prenatal visit in the first trimester, as well as the percentage of deliveries of live births that had a postpartum visit between 7 and 84 days after delivery. Now, I know I just talked about the expansion of coverage being up to 12 months, and so while we do have that expanded coverage in Virginia, the national measure of postpartum care is still going to be that 7 to 84 day window. But DMAS is still going to be measuring that internally up to 365 days. And I'll show you in a few slides how we do each of those things. Next slide, please. Oh, perfect. All right, so this first slide shows the percent of deliveries of live births that received a prenatal visit in the first trimester. So this slide and the next one are going to be all about prenatal care. So this particular graph shows the then 6 managed care organizations that were contracted with Virginia Medicaid and the results in measurement year 21. Currently, there are 5 MCOs partnered with Medicaid. So you'll see 6 bars there. It's just because of the timing of when what this data is showing. So in addition to being able to see the, oh, sorry, can we go back? Yeah, thanks. In addition to those 6 bars that represent each of the MCOs, we also do have the state average and the national 50th percentile, which kind of helps give us some additional context for the MCO and the state's performance, so that we can see how we stack up against the other reporting states. So now this next slide shows the exact same measure that we were just talking about, but now it's going to be showing it trended over time, the last 3 measurement years. As with any kind of trend line, this helps us see if there are any significant increases or decreases in performance over the last 3 measurement years, instead of just that snapshot in time that the one singular 1 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 All right, so now this measure is going to be very similar to the two slides ago, but now we're focused on the postpartum visits, right? So now we're looking at the percent of deliveries of live births that had a postpartum visit between 7 and 84 days of delivery. And again, we're looking at the performance of the MCO partners, which account for over 95% of Virginians receiving Medicaid, and how they compare against that national and state average. And the next slide, similar to the other trended slide, now we're seeing the postpartum data, but trended over the last 3 measurement years. And again, to be able to see any big changes, obviously, we're going to see a bit of some bowing there as we get into the time frame with COVID, and we saw utilization across the board taking dips, especially when it comes to more preventative care type services. So those were how we look at things with the official HEDIS scores. Now, the next few slides are screen grabs from an internal dashboard that we made to help us monitor postpartum care more regularly. So while the measures that we have on these next few slides use the same formula for calculating postpartum care as the HEDIS data, it doesn't have the exact same ingredients. This is because this data does not include a medical record audit like the NCQA HEDIS data is able to perform. But this information is still very valuable to us because while we trust what these numbers are showing us, they're a helpful indicator for how we think that the HEDIS scores will look directionally. It's not going to have the same magnitude. Our numbers are always coming up about 15 to 20 or 25% in some cases lower than the HEDIS score because of that medical record audit not existing. So, but again, the value here is that we have the ability to see the postpartum rates earlier in the year, right? So instead of waiting for every October to see how we did over a full year ago, we are only held back by claim lag, meaning that it takes time for hospitals to submit claims to the MCOs and to DMAS for us to see that there was a birth event and or a medical doctor visit or medical encounter there. So so still lots of things to learn from this, but I do want to put out that caveat of why the two numbers are going to be different and why these numbers are going to look lower. But again, a bit of a canary in the coal mine as far as this dashboard is concerned. It also gives us the ability to look at the postpartum rates by the time frame windows that we talked about earlier. So we have the 7 to 84 day like HEDIS, but then we also have the 85 to 365 day postpartum expansion view as well. So being able to just basically add the two numbers together to represent that 365 view. We also do have demographic data on these members as well. So then the next slide is going to show the underlying data for these same line graphs that we were just looking at. This is especially helpful to me if I need to look at things in a different time period. We're showing this in terms sometimes of either fiscal year or calendar year, or as you see here, we had a baseline period for a separate project. So really being able to have the underlying data here, I can create different time periods that suit whatever the request needs to be able to show on it, but very helpful. In addition, it's not as obvious on this slide or the previous one, but in addition to looking at what would typically be counted as postpartum visits from the HEDIS definition of postpartum care, we're also able to look and see any of these members that fall within this cohort, right? So any people with a delivery in that month, we can also see maybe they didn't have a postpartum visit in the sense that they went and saw, you know, an OBGYN or a general practitioner, but also if they had any kind of emergency department utilization, maybe a behavioral health service claim, anything where we believe that they were touched by a doctor. We have that, and we can try to use that information to then see if we need to change a program or change the outreach in order to get members who are seeking those alternative places of service and get them into something that would fall within that HEDIS definition of a postpartum visit, making sure that these members are receiving the important care after a birth event. This next slide highlights that we also have, in addition to that utilization category filter that I talked about, but also that we have added in the ability to look at this by locality. So by city and county in the state of Virginia, we can look and see where these birth events are taking place, and, or excuse me, we're able to see postpartum details by locality. This is especially important to me in the agency because it allows us to easily track the progress made in certain areas. So for instance, in Petersburg, right? Petersburg City is a locality in Virginia, and this that's the location of an initiative from Governor Glenn Youngkin with his Partnership for Petersburg project. So we need to be able to have that data readily available to be able to show any changes in them in their postpartum rates, and to be able to see, are the outreach mechanisms that the agency is using, are they working, or do they need to do something different? So this is a very helpful additional piece to this tool to help us with being able to look at the data a little differently. So this is just a list of some other data sources where we can get information on our members and other trends about healthcare quality. Yeah, so we have these plus the HEDIS dashboard and the other internal dashboard from the previous slides. These are all being used by the agency, and there's even a group that Marina helps spearhead, where they're proactively using this. They're using all this information to proactively look for areas of opportunity, for ways to either add on to or think new things to consider for our programs and policies to enhance the care that we give to our members for prenatal and postpartum coverage, to make sure we're taking care of not only babies, but not only baby, but also mom. So that's all the information that we were planning on sharing with you all today. So we definitely thank everyone for your time. And at this point, we welcome any questions that that anyone may have.
Thanks so much, Marina and Rich. Really appreciate that overview. I was wondering if you could describe the claims lag and the specific time frame for what is posted on the website, which from what I understand is publicly available. So anyone can go out there and look at those HEDIS measures. And then the internal, I know you said the internal is a little faster, but if you wouldn't mind sort of describing that and sharing if there are any plans to update the public facing website in the future with different data or more recent data, or sort of what that looks like, just so people know what's coming. Thanks.
Sure. Yeah, great question. So to answer the first question about claims lag, so for us, we just draw a line in the sand and about where we feel like the claims are complete when we look at that. So sometimes for some areas, it might be as little as 90 days. So we could maybe look at data through, I guess if this is the start of April, we would feel very confident with all of the information available through December 31st, maybe even January 31st. If it's more of a doctor's office claim, but if it's a hospital claim, an inpatient stay, especially delivery, that could take anywhere from 6 months all the way up to almost a full year. So in that regard, we would hold back our postpartum data because we wouldn't want to have a lot of zeros pulling things down incorrectly and having people draw the wrong conclusion. So for our internal dashboard, we run about, I believe we've been running a 6-month lag on that. So so that we can make sure that we have the full amount of data available for that and feel like that we're communicating the right outcomes there. As far as the public-facing HEDIS dashboard, their timeline's a little different. Things are a lot more in the rear view mirror than even that. So measurement year 21 reflects basically October 20 through September of 21. And so we're working to get new data that has measurement year 22 added to the website so that we can have another year of trended data available, especially as we're getting slightly further out from impacts of COVID and how that changed utilization habits. But that would be available on the website. It's just with that medical record, excuse me, with that medical record audit, it takes even longer for that information to come through. But once it does, it's complete. It's complete.
Thanks so much. I just have another sort of a follow-up question. So the goal of this data series is to promote collaboration and partnership and maybe even a little bit of innovation as we try to tackle the maternal mortality crisis here in Virginia. So I'm wondering, does DMAS share this data regularly with the managed care organizations, and are they in a position to make that data available to potential partners? Or is there an avenue for community partners or health systems or other entities to learn about more recent trends so that they can pivot, right, to address what may be something that's happening in their community at the locality level?
Yes, so I do know that the program teams and the maternal health teams meet with all the MCOs and discuss what they're seeing, both from DMAS to MCO and from MCO to DMAS to communicate what they're seeing. Beyond that, I'm not 100% sure. I'm not always involved in those meetings. I don't know if Marina, if you have any additional insights, but as far as what the MCOs are able to then do, part of the benefits of Virginia being a managed care state is it allows those MCOs to do innovative programs so that, if we have 5 MCOs, there could be 5 different, interventions or things going on to try to improve those health outcomes. So I think there are plenty of innovations, who they share that information with, or who they have contracts with. I'm not positive on, but I'm sure someone in our agency might have more insight into that than me.
Yeah, and to add to that, I think we're really focused on broadening and improving our collaboration with other partners in addition to the managed care plans. We've talked amongst ourselves about the best way to share data and to make that available to our partners. And it's tricky because I had a professor who would always say data are dirty, right? Like data is very specific to, you know, an organization and how you utilize it and how you organize it. And so what we would encourage our partners to do is to reach out to us with a specific request that they may have, and we can provide, we can pull the data and provide some analytics on a case-by-case basis, you know, depending on the need. It's probably the best way to approach it, and provide that kind of insight into what we may be seeing.
Really helpful. Do you have a contact or an email where folks could reach out? Is there a general DMAS data email that they could access, or is there an online form? I know some organizations have that. So just checking.
I think probably we're the best contacts. We don't have like a
Catch all.
vanity email or anything on the website. So happy to provide our contact information to this group. Yeah.
Yeah, that would be great. If you wouldn't mind just dropping that into the chat is probably the easiest way so folks can get a hold of it. I know Evan from VNPC is our lead for opening the meeting today, and just wanted to check in with Evan to see if there were any questions in the Q&A.
I don't see any, and I don't see any in the chat, but if any pop up, I'll be happy to share.
Okay. And if anyone wants to come off of mute, if you have questions for Rich or Marina, I'm sure they would be happy to answer. And thank you for dropping your emails in the chat. That's very helpful. Dr. Ollendorf.
Hey, thanks for this. This was super helpful. Fully understanding that data is dirty. I used to work with North Carolina Medicaid, and we were always struggling with that. But also the potential for predictive analytics is huge. I mean, this is the highest risk population we have in Virginia. The ability of doing simple things from heat mapping, you know, especially with maternity deserts, like what is the postpartum visit rate in Southwest Virginia where I live? It's probably pretty low since they're traveling hours for care like that. Those type of things help us think about policy and figure out things, but also, you know, is the data, albeit not clean, is it clean enough to say, you know, can we predict people are going to have bad outcomes? You know, do we know that severe maternal morbidity is linked to failure to have a postpartum visit? We think it is, but I don't know if that's true or not, right? Like, do we have the ability and the mechanism to do that as we try to do better for the women and birthing persons in Virginia and figure out, hey, what can we do? Not to say, wow, look what happened to you. Like, how can we prevent that from happening to you and to your family? And can you link kids' outcomes if they're in CHIP to maternal outcomes? Because we have an infant mortality problem, which we're not sure if it's related to maternal mortality or not. I mean, there are all these potential, I mean, the data set's so massive and it's also limited. So I'm not sure what comfortable technologically and otherwise we can do with this to do even greater things.
Yeah, absolutely. That's excellent points. You know, I don't know if I would call this predictive analytics, but certainly it was be an application of how the data is being used to help provide preventative care, which is the agency very recently has started to work, or at least very recently discovered the high correlation between postpartum mortality and Black women and cardiovascular issues. So there's a lot of work being done on that with our chief medical officer and other different individuals in the agency to try to use that conclusion to make sure that certain individuals that might be at a higher risk of cardiovascular issues are certainly getting in, knowing there are any warning signs that they're working to get into seeing their doctor. But I think that's to your point, I think there is a lot to be done. Normally we do actually have geographic mapping in many of our Tableau dashboards to be able to find that that coverage, see if there are any gaps in access and networks. So the views you all saw are certainly more of a version 1 for the internal dashboard. Like I said, it really just grew out of me needing to have certain pieces of information ready at any moment. And so we're still trying to see what we can add in, not only for postpartum visits, but how to do something similar for prenatal visits. And then also, as you were touching on, what can we do to help make sure that we're monitoring, actual birth outcomes, and what constitutes having a healthy birth outcome? How do we define that, and then how do we go about measuring that?
No, thank you. Sounds awesome.
Yeah, and I guess as a bit of a wait and see for everyone, a bit of a teaser. In addition to these HEDIS measures, there's going to be the core set measures, which I don't know if anyone is familiar with, but DMAS has been hard at work and actually very ahead of the game on having those ready. They will start going live next year. And so we'll start to, once those go live and go through the approval process with CMS, we'll start posting those online as well. And that's one motivator for why the other dashboard is staying internal, because I just honestly didn't want to have 3 different definitions of postpartum care floating around on the internet for Virginia Medicaid, because I know that could be very confusing for a lot of people. That's why I spent a few minutes trying to carefully explain why even the HEDIS and postpartum measures we were looking at are going to be different, because we're going to be having a possible third definition, but we'll make sure we have a strong communication and rollout plan for that. But it is something that I think will help give us more views into this type of quality data as it pertains to prenatal and postpartum outcomes.
So much, Rich. Would you mind, just to make sure everybody is aware of, just speaking a little bit about what the core set is and what those measures, not maybe specifically what they are, but just define it for us, I suppose, just in case someone is coming in without that level of knowledge.
Sure. So it's going to be a new way for CMS to be able to look at all states, or look at the to be able to look at all states evenly. Currently, HEDIS is the closest thing to that within CQA, but not every state is participates. So this core set will try to continue to provide a more standardized way of looking at so many different perspectives of healthcare services for Medicaid.
And that's including the postpartum visits, and I think there's a cesarean metric in there as well, like a low risk C-section measure, and a few metrics specific to infants and birth weight and healthy development. So looking forward to that. That is something.
Yeah, it's a couple dozen. So we're working on making sure that we are well positioned to participate fully once it goes into effect next year.
Yeah, thanks. We love a teaser. We love to know what's coming. So thank you for sharing that. And Dr. Ohlendorf, yeah, I see, wondering how HEDIS is going to be capturing postpartum care where there are multiple visits that address a specific set of issues over time. So I was noodling on that as well, thinking about mental health, substance use, right? Other things that might happen in the postpartum period that would require multiple touch points. perhaps more frequently than just the one visit. And who knows what the NCQA gods will do. Marina?
Yeah, I was just gonna say, yes to everything that's been said. And there's so many additional directions that we want to go with the data that we have. I don't think that we've fully, realized the potential of our own claims data. And I think looking at care pathways for certain types of conditions through the claims data would be really interesting. There's also a study that our external quality review organization does for us on an annual basis called the Maternal Child Health Focus Study that identifies additional areas where we might want to investigate for further, healthcare quality improvement. And that study is going to be posted on our website, the most recent version, I think any day now. So what I'm discovering is that you can look at the data, but then I think the next step is like making meaning from it. And that's where I think this group will be really, really useful in helping to kind of add some contextual information about what our Medicaid members are experiencing as they're seeking care so that we can help develop some solutions. So data is kind of the starting point.
Absolutely. It always is a good place to start, but it's not where you want to finish, right? Necessarily. You don't want to start and end right with the data. But actually go out and enhance that with more experiential information, right, from the field. And I think just putting a plug in for the VNPC and the bundles that they are working on for quality improvement is where you can take some of this data, right, and apply it to inform, innovation initiatives to address these problems in a structured and collaborative way, right? And then you come back to the data later to see if you made a difference, right? That's the trick, is keeping that consistency. So definitely appreciate it. Appreciated your overview of the data that DMAS has to offer, what's coming next, some of the challenges, discussing the data sources, and looking forward to the core set of measures. And noting that Dr. Ohlendorf mentioned North Carolina and California Medicaid have some care pathway work that they have built out based on those data sets. So that could be a nice example, right, to look to. It's always easier to edit than to create, I have found. So taking something and looking to see how we might be able to apply that here in Virginia could be valuable. Any other questions from the group? You can hop off mute or raise your hand. Anything in the Q&A, Evan?
No, it doesn't look like it.
All right. Well, Marina and Rich, thank you so much for sharing this information. We are really happy to have DMAS participating in this collaborative effort, and just reminding everyone that there are more sessions to come. We have another one coming up that's going to be on May 14th, same time, same place, right? From noon to 1 p.m. And so please join us. At the top of the chat, there's the registration link. So if you have folks that you know who would benefit from this, please do encourage them to register and join us. Also, I know that VNPC is recording these and will post them on their YouTube channel, I believe, which is accessible through the website. So thanks everyone again for joining us over lunch, and a special thank you to the VNPC and our partners at DMAS. And I hope everyone has a wonderful